Hey everyone, for this one we're going to describe the cardiovascular changes that occur with morbid obesity. So the structure of this video will be intro and definition. Then we'll talk about the cardiovascular system, which I've divided up into heart, vasculature, and blood. To begin with this question, let's just define obesity. So obesity is defined as a BMI greater than 30 and morbid obesity is a BMI greater than 35. I like to start with a sentence or a phrase just to set context for the question and the answer. So obesity is becoming more common and has many effects on the body due to increased adipose tissue mass, neurohormonal changes such as leptin, pro-inflammatory state, insulin insensitivity, and other adipokines, and association with poor health and other comorbidities. I say association here because it is possible that you can be morbidly obese because of other conditions that are out of your control and not lifestyle related. So first we can talk about the heart. A technique I use in exams when I'm lost and under pressure and need to be able to talk about something is try and break it down into simple steps and give yourself some headings to then talk about. So with the heart, we know that it pumps blood out, so cardiac output's important. You can break cardiac output down into heart rate, stroke volume, and then stroke volume is dependent on contractility, preload, and afterload. Talk about the conducting system as well. And then simply with heart rate, so heart rate in obesity isn't necessarily increased or decreased. It generally is normal at rest. Stroke volume is increased. Contractility can be normal or decreased. Preload is usually increased, and afterload can be normal or increased. And conducting systems, there's a risk of arrhythmia. For the heart rate, so in obesity, people become more heart rate dependent due to stroke volume being increased and being at its limits. So you can't really rely on stroke volume. And as we mentioned, contractility is normally normal or decrease. So your heart rate becomes the dependent factor on cardiac output. Stroke volume usually becomes increased, and this is due to increased blood volume, which we'll talk about preload, but increases your preload as well. And then contractility can be normal or decreased. And this is dependent on many factors. So it can be decreased if there's fatty infiltration, ischemic heart disease, cardiomyopathy, all of those things that would decrease your contractility, but can also be increased because of the Frank-Starling mechanisms if you've got increased preload. But this is to a certain extent, because as we know with Frank-Starling mechanism and your cardiac contractility curves and preload curves, if your preload gets above a certain point and your heart stretches too much, you lose contractility. So we've already mentioned it twice now, but preload increases, and this is due to your increased blood volume. So you have an increased mean systemic filling pressure as well. For afterload, a common misconception is that the more fat someone carries, the higher your blood pressure needs to be. Now, this isn't necessarily true because the capillary beds that are added to fat are in parallel to other capillary beds, meaning that your actual length of vessel that you're pushing blood through isn't necessarily increased, and capillary beds aren't a major factor in systemic vascular resistance anyway. So you wouldn't write that it increases blood pressure necessarily, but it does. Usually being overweight carries the risks such as other comorbidities and poor lifestyle choices that could lead to increased blood pressure and increased afterload. Now, there's a risk of arrhythmias with obesity as well. So there's fatty infiltration of the conducting systems. There's risks of heart blocks with that. Usually you see a prolonged QT on an ECG and ischemia. On the ECG as well, classically you'll see lower voltage because there's more distance between the heart and the electrode. So the sensing electrode will sense a smaller and weaker signal from the heart. And you can get left axis deviation if there is increased afterload and increased hypertrophy, though generally you'd get an eccentric hypertrophy first due to the increased blood volume. So for vasculature, I like to break it down into peripheral and pulmonary. Pulmonary is often an area that people forget to talk about, but it's an area that you can maybe get a few extra marks on if you remember it. And peripheral, I break down into systemic vascular resistance and endothelial dysfunction. Now, we already talked in depth about systemic vascular resistance, but it can be normal or increased. And your endothelial dysfunction is usually more apparent in obesity. Just to reiterate, so systemic vascular resistance, so fat itself doesn't increase systemic vascular resistance, and this is because the capillaries are in parallel to each other. So their cross-sectional area is actually larger meaning that there's going to be lower resistance in those capillary beds. But the risk to increase systemic vascular resistance is usually because of the other comorbidities associated with obesity that then can increase your blood pressure. For endothelial dysfunction, if you've got increased cholesterol in your blood, there's more likely to be increased endothelial inflammation as well. There's increased risk of atherosclerosis, which then increases your risk of coronary artery disease, strokes, and renal artery disease. Obesity is also associated in general with a pro-inflammatory state, which leads to endothelial dysfunction as well. Pulmonary hypertension is one that isn't so obvious, but it's becoming more and more common. So in obesity, you're more likely to have sleep apnea. You're also more likely to have obesity hyperventilation syndrome. And this leads to a chronic decrease in your partial pressure arterial O2 and increase in your partial pressure arterial CO2, which leads to hypoxia and pulmonary vasoconstriction, which leads to pulmonary hypertension. And then pulmonary hypertension as an add-on effect can then strain your right heart, which leads to right heart failure, or cor pulmonale as it's also known, and fluid retention. Another thing that can be seen is that you can get polycythemia, so increased red blood cell production, and this can increase your blood viscosity, and this is triggered by that chronically low PaO2. I haven't mentioned it here, but sleep apnea also has an association with atrial fibrillation, so you have increased risk of that as well. Lastly, we'll talk about blood. And when we talk about blood, I'm going to talk about volume and coagulation. So in obesity, you have increased volume and increased coagulation. So your increased volume is from an increase in body mass in general, which leads to increased blood volume. You also have increased sympathetic nervous system stimulation, floating around leptin, which is a hormone that comes from fat, and other neurohormonal pathways that are being activated. You'll get increased angiotensinogen synthesis from the liver, which means that your RAS process will happen as well, which will lead to fluid retention. And then remember, we mentioned pulmonary hypertension and right heart failure, and this can lead to fluid retention as well. For coagulation, because of being in a pro-inflammatory state, there's increased circulating cytokines such as TNF-alpha, interleukin 6, which will lead to increased coagulation. Also, if you have decreased mobility because of being overweight, you can have a stasis of blood in the lower limbs, which leads to an increased risk of venous thromboembolism. So that was a crash course on answering the question about the effects of obesity on the cardiovascular system. If you guys have any comments, anything that you want to ask, or anything you want me to cover, please feel free to comment.